federal regulations make sense for application. Let's move to the timeline for mental health parity analysis. We'll be providing a series of webinars, as you're, I'm sure, aware. Webinar 1, we're covering the overview of the rule and QTLs, the quantitative treatment limitations. Webinar 2 will go into the non-quantitative treatment limitations, that's NQTLs. Webinar 3 will look at documentation requirements and make up topics based on the questions that we get from you from the first two slides, the first two webinars. The Webinar 4 will extend on questions that you raise and provide a troubleshooting forum, and that will be the same context for Webinar 5. In addition, we want to provide one-on-one check-in opportunities with each CCO to understand your progress and provide technical assistance as needed. And the final and very important date is May 19th, which is the due date for the CCO's mental health parity analysis. So that will be due on May 19th. So the first webinar is looking to provide an overview of the mental health parity rule and its application in the Oregon context. We'll be going through definitions, the benefit classification process, and general analysis information before we look to the task of identifying and analyzing QTL, the quantitative treatment limitations, as well as identifying resources and a process for registering questions. The first part of the presentation looks at the mental health parity rule overall, focusing on the federal regulation and the OHA-CCO collaboration for doing this analysis. So the 2016 rules under the Mental Health Parity and Addiction Equity Act, MEMPIA, the law runs as follows. It requires group health plans to ensure that limitations on mental health or substance use benefits are no more restrictive than the limitations applied to medical and surgical benefits. The rule, published in 2016, applies the law to Medicaid and CHIP services specifically, and prohibits the application of more restrictive limits to mental health and substance use disorder benefits than those that would apply to medical surgical benefits. So the timeline, looking at how we got to today, an earlier act, 1996, the Mental Health Parity Act, looked at aggregate limits and that were looking to limit application of mental health if they were not applied to the medical services. 2008 Act, the Mental Health Parity and Addiction Equity Act, MEMPIA, requires full parity for financial and treatment limitations, and it's the basis of the rules that we're looking at today. So the final rule for Medicaid CHIP came out in 2016 and applies MEMPIA to Medicaid and CHIP. The CMS provided training to the states on the application of the final rule starting in February 2017, and we have based this work or technical assistance on that guidance, but we've tried to make it more understandable for CCO application. And then finally, that October 2nd deadline, which is significant because the compliance with the parity rule must be posted on a public OHA website, so there is visibility in terms of that compliance deadline. Something that we really want to get clear right up from the start is this isn't like previous parity laws. And here's an example for that in terms of work that was done by the Health Evidence Review Commission, or HERC. Looking at occupational therapy, occupational therapy had a limit of 30 visits per year, and mental health SUDS seems compliant, but now this compliance must be changed to meet the new parity rule. So MEMPIA concepts might seem counterintuitive, but they're part of the rule. So here's the example. Occupational therapy is an outpatient service. If provided for autism spectrum disorder or any mental health SUDS diagnosis, it's a mental health SUD benefit, even though OT is not generally thought of as a mental health SUD provider. Now, in this example, limits which apply to any mental health SUD service in an outpatient setting must apply to substantially all medical surgical benefits in that category. The solution to this challenge is Rather than apply a limit to all outpatient services, including office visits, labs, and non-emergent transport, HERC removed the 30-visit limit for occupational therapy when billed under any medical health diagnosis on the prioritized list. Now, as we move through this webinar, I think that this will become clear sort of in a series of demonstrations and illustrations and examples. So if this seems a little bit murky, please don't think that you're alone. It is a new way of thinking about parity. So let's just sort of work through it, and as we work through it, I think it'll become increasingly clear. In terms of requirements, the final rule for Medicaid CHIP requires systemic analysis of treatment limitations. The final rule requires the states ensure that CCOs meet these parity requirements, and to do this, the CCOs must submit an analysis of how they currently meet these requirements. The CFR, the rule, requires that the results of this analysis be posted on a public website maintained by OHA by October 2nd. So there are internal deadlines to get to that point, because there's a number of steps that will be required to get to that documentation step. So who is doing what in terms of the mental health parity analysis? And we're focusing on the CCO roles and what OHA will be doing to support and take the lead on compliance. We really want to work together and provide the technical support that you'll be needing to get through this process. So the OHA responsibilities, well, OHA is taking lead on parity analysis in the following areas. We are doing the full analysis for parity for fee-for-service benefits. We're looking at parity for carved-out services like mental health related pharmaceuticals and the 1915 home and community-based services. We're also looking at parity for med-surg services delivered to CCO and CCOG members, and we'll be working together with the CCOs on that. The result of OHA's analysis informed this webinar series and other technical support provided to the CCOs. OHA will work with CCOs to bring them into compliance, and this is a collaborative effort, and will document the compliance and meet federal requirements regarding applicability of medical necessity criteria and reasons for denial of service. So let's look at the CCO responsibilities for parity analysis, and let's sort of check through this. To ensure CCOs meet the mental health parity requirements, CCOs must analyze how the CCO currently meets mental health parity requirements for its members by conducting a thorough review of services and policies. This includes analysis for members receiving all or partial OHP plus services. The CCO must list all quantitative and non-quantitative treatment limitations the CCO imposes, including those imposed by subcontractors such as IPAs or MHOs for mental health and SUDS benefits. And there'll be more on that later in the presentation. CCOs will need to work with OHA to bring these policies into compliance, and this is, again, a team effort, and document compliance to meet the federal requirements regarding applicability of medical necessity criteria and reasons for denial of service. So the who and the what extends to the services that we're talking about. So we're focusing on what is generally known as OHP plus, and that is a roll-up of Medicaid, CHIP, and ABP services. So OHP plus is the benefit package being analyzed by the CCOs, and OHP plus comprises Medicaid, CHIP, and alternative benefit package for ACA expansion population. So all of that together is what we're calling OHP plus. Now, the CCOs and subcontractors will be looking at across their delivery systems. And so let's sort of define what delivery system means for the purposes of parity analysis. Parity analysis must include CCO limitations within the entire CCO system, including subcontractors. A separate analysis must be conducted for each CCO subcontractor combination. So we're talking about not only the CCO itself, but also mental health organizations, independent practice organizations, county mental health programs, and other subcontractors. In conjunction with OHA, A separate analysis must be conducted for each split service. So let's spend a little more time looking at the parity requirements themselves. So this involves looking at the rule objectives, the deliverables. We'll be looking at the definitions that we need to do implementation, and look at the analysis framework. So the 2016 rule requires parity in key areas, and the two main areas are these: quantitative treatment limitations, and we'll be calling those QTLs. The rule is a prohibition of these QTLs, such as days per episode, to mental health and SUD benefits that are more restrictive than the predominant QTL applied to substantially all medical surgical benefits. So any QTL on mental health, substance use disorder versus substantially all medical surgical benefits. It's a high bar to get over. And we'll talk about that and the analysis around that going forward. The other major area is non-quantitative treatment limits, or NQTLs. And this prohibits these non-quantitative treatment limits on mental health and substance use disorder benefits. And this would be, for example, determinations of medical necessity. Prohibits NQTLs unless any processes, strategies, standards, or other factors used in applying NQTLs to mental health benefits as written and in operation are comparable to and applied no more stringently than those used in applying the same NQTL to medical surgical benefits. And that's a big overall requirement, but essentially it's looking not simply at the statement of the limitation, the NQTL, but it's also looking at how that NQTL is actually applied in operation. So the deliverables, specifically under the 2016 rule, are the documentation of the mental health parity analysis, and requires the states to ensure that the CCOs meet these requirements and document this compliance on a public website. In addition, there's an availability of information requirement that looks at getting the criteria for medical necessity determinations on mental health and substance use disorder benefits made available to the beneficiaries and providers upon request, and requires the reason for any denial for mental health substance use disorder benefit be made available to the beneficiaries. So let's get into some of the definitions that we'll need. And some of these I think will be very familiar, and we'll move quickly through them. Some of them I think are new ideas, and we'll want to pause a minute. So let's spend a little bit of time looking at QTLs, or quantitative treatment limitations. So QTLs limit the scope or the duration of a benefit, and these limits are expressed numerically. QTLs can affect access to treatment by capping a benefit. So some examples of QTLs are frequency limits on the frequency of a treatment, annual visit limits that limit visits per year, episode limits, say length of stay, annual day limits or days per year, and waiting periods, the days in a waiting period. And then looking at NQTLs, or non-quantitative treatment limitations. The definition then looks at NQTLs as limits on the scope or duration of benefits using NQTLs such as prior authorization or network admission standards. So examples of NQTLs include medical management standards, including limiting or excluding benefits based on medical necessity or appropriateness of criteria, standards for provider admission to participate in a network or reimbursement rates in network, restrictions on services based on geographic location, facility type, or provider specialty, fail first policies, step protocols, and exclusions based on failure to complete a course of treatment. So let's drill down a little bit more and look at the additional definitions for analysis and get to a view of the analysis framework that OHA and the CCOs are going to have to step through to reach a level of analysis that meet the requirements of the 2016 rule. So we'll look at mental health and medical surgical categories, and we'll look at benefit classifications, and then look at how this all sort of fits together. So let's actually start a little bit higher up in terms of the overall framework. And this, I think, this may begin to get at how the analysis sort of breaks down and works across different delivery systems, across different services and diagnoses. So the analytical process can be understood in the form of a grid showing the intersection of diagnoses and conditions. So we're looking at mental health diagnoses versus medical surgical diagnoses. And those diagnoses then determine or relate to treatments or services provided. And we then map the diagnosis to the services or treatments. So the diagnosis is the first step, and then determining which treatments are mental health or surgical treatments before we map them into service classifications. And then within this framework, we look at the degree to which there are limitations on such as NQTLs and QTLs. If that is as clear as mud, there are plenty more slides to sort of help you sort this out. So let's just step back and look at some of the definitions for medical, surgical, and mental health, substance use disorder definitions and treatments. So there is a bright line, which I think is going to be very helpful. Medical, surgical treatments are determined by the underlying diagnosis. So medical surgical benefits means benefits for items or services for medical or surgical conditions specified in ICD-10, except for the Chapter 5, the F-code diagnoses. The mental health substance use disorder benefits are benefits or items or services for mental health conditions as specified in ICD-10, Chapter 5, the F-code diagnoses. So the bright line is that what's in or not in Chapter 5. Now, this aside at the bottom of the slide is extremely important because it really gets at the core of the analysis. Benefits are assigned to medical surg or mental health buckets based on diagnosis, not by provider type or delivery system. For example, an office visit or an ER visit for a mental health diagnosis is in the mental health bucket, even if we think of it as a physical health provider type. So let's look at identifying mental health services or treatments. So when we look at services or treatments that are related to mental health or substance use disorder diagnoses, getting that definition is the first step in evaluating parity. So the core of the parity analysis is mapping which conditions fall into the med-surg or mental health buckets. This is a bit of a review from the last slide, but for clarity, for the purpose of Oregon's Medicaid parity analysis, the current ICD-10 has been adopted for mapping these buckets. Specifically, again, OHA defines ICD-10 F codes as mental health diagnoses, and all billing codes pairing with an F code are considered mental health services. So for an example, ICD-10 classifies anorexia nervosa as a mental health condition. Therefore, nutritional counseling for the treatment of anorexia nervosa is a mental health benefit. And then another cut here is to break out the treatments or services into 4 classifications. These are inpatient, outpatient, emergency care, and prescription drug. And the other attachment or resource for this presentation is the OHA mapping guide, and that provides guidance of sorting or mapping these treatments into classifications. And we will not, because it's a fairly huge and detailed document, we'll not be going over that specifically, and there will be opportunities later to drill down on that in further webinars and Q&A and FAQ documents. But that's the full view of this mapping process of med-surg and mental health and the inpatient outpatient classification. So just real quick, because these classifications should be fairly familiar to folks that are operating under the Medicaid arrangement now. So inpatient refers to a situation where a patient has been admitted to a medical institution for 24-hour period or longer. Outpatient is the mirror image, where there's been some sort of service delivered in a facility for less than a 24-hour period. Prescription drug classification refers to simple or compound substances prescribed for the cure or mitigation or for health maintenance. Now, this is an important point. I think this lists some of the burden for the CCO analysis. OHA has determined that it has no QTLs or NQTLs for prescription mental health drugs. So no analysis of outpatient pharmacy benefits will be required for the CCOs. So that's a classification that we'll cover at our end, and you can sort of pass that part over to us. The final classification is emergency care, and that is familiar, is furnished by a provider that's able to provide those services, specifically services that are required to evaluate or stabilize an emergency medical condition. So now let's look to the how. Let's look at how parity analysis is to be conducted, how we've done it for QTLs, and how this will bring across QTLs and non-quantitative treatment limits as we move forward. So first we'll talk about setting up for parity analysis, a general view as to how this is conducted overall, and then we'll look at how OHA has done quantitative treatment limits and share some of the experience that we've gathered from that process. So overall, the steps in the parity analysis process are first to identify the mental health benefits, and again, that's based on diagnoses. Then we map those benefits to the 4 classifications, inpatient, outpatient, et cetera. And then we identify and evaluate treatment limitations. So a bit of review here before we move on. The parity analysis setup starts with the requirement that we verify that limits to accessing mental health and substance use disorder treatments are no more stringent than limitations applied to med-surg benefits. Again, a treatment must be identified as either med-surg or mental health based on the underlying diagnosis. This sorting is based on the condition, Chapter 5 of ICD-10, and in each encounter, a treatment may be identified as med-surg or mental health based on the diagnosis, not the provider type. These treatments are aggregated into med-surg or mental health buckets for the purpose of parity analysis, and this parity analysis is conducted within each benefit classification, such as inpatient or outpatient. So a little bit more about the mapping guidance, this more extensive document that you have available to you. It contains all of the fee-for-service definitions for general categories as well as for benefit classification. The OHA mapping guidance chart supports analysis of the mental health services versus medical surgical services and differentiating between substance use disorders, mental health services versus the medical surgical services. And this will apply to all services potentially available to a member with OHP Plus, including state plan services, as well as other services like volunteer services that a CCO may offer. And note that the 1915 waivered services are included in the state fee-for-service analysis only. So we have those services we've got on the OHA side. That's our work. So let's look at how we did the quantitative treatment limit analysis. So this is sort of the state's work that we'll share with you. We start with the parity rule itself, but we're looking at OHA recommendations on how to do the analysis in a straightforward way that I think will limit the amount of work that's required to get through this process. So we'll look at the initial QTL analysis, alternative strategies, a 2-part test, which hopefully does not come up much. It's a lot of work, and I think it may well be avoided in most situations. We'll provide an OHA example about how we did it, and talk about additional steps for setting up the analysis. So let's turn to the parity analysis rule, the 2016 rule. And this may be familiar to you, but I'll state it again here. It prohibits the application of QTLs to mental health sub-benefits that are more restrictive than the predominant treatment limitation of that type applied to substantially all medical surgical benefits in that classification. That's a mouthful. We'll work through it. But here's a translation. In other words, if you have a mental health sub-benefit with a QTL, and you must prove that that type of QTL is applied to substantially all medical surgical benefits in that classification for that mental health sub-benefit to be compliant. In addition, if that's true, it does apply to substantially all med-surg benefits, then we need to look at the level of that limitation, and there's a mathematics for doing that. So let's do a quick look at how to do a compliance check, an initial QTL analysis. And this may yield good news. The good news is that detailed financial modeling may not be required. This chart here shows the conditions or the situations in which QTLs may already be compliant with the final rule. So let's look at this chart, and let me kind of set it up for you. We're looking at, let's say, a given QTL, and whether it applies to medical surgical treatments versus the mental health treatments. So in this first line where you see none, none, it means there are no QTLs on either med-surg or mental health. In that maybe rare situation, the case is that there are no NQTLs, so by definition there's parity. There are none in either category. We're compliant and no action is required. Now let's look at a situation where there are QTLs for medical surg, but none for mental health sub. Well, in that case, the med-surg category is more stringent than mental health, so you're compliant and no action is required. Now, in a situation where a QTL applies to med-surg and the very same QTL applies to mental health, then if the same standard is for both, then they are at parity and they're compliant. Now, in a situation where there are QTLs for both, but the mental health sub QTL is less stringent, then that is compliant and no action is required. So the category that is going to require additional work is a situation where there is a QTL for the med-surg, and the mental health QTL is more stringent than the med-surg QTL. That is not compliant with the 2016 rule. In that case, action is required. So the mental health sub QTLs that do not initially demonstrate parity requirements will require further analysis. And the strategy here is, let's look at fixing the QTLs first before we go into any financial modeling scenario. So here are some alternative strategies for compliance. When a mental health sub QTL does not immediately demonstrate parity, it may be brought into compliance without further analysis. So let's look at some of the alternatives. Here are some options when mental health QTLs are more stringent than med-surg QTLs. One option is to adjust the mental health sub QTL downward for parity. And that would be, sort of reading back to the beginning of the presentation, we were talking about occupational therapy, and we ultimately eliminated the mental health QTL down to zero, to essentially to no limitation, and that brought the mental health QTL to parity by eliminating that requirement. That's making it by definition less stringent. Another alternative would be to make the med-surg QTL more stringent to bring it into parity with the mental health QTL. Another option is to take the quantitative limit and change it to a non-quantitative limit using a soft limit with medical necessity perhaps as a basis for applying exceptions to the QTL or to the rule. And then finally, the last resort, and frankly, from the sheer weight of the analysis and the likelihood that most QTLs simply won't pass this test, you can, if you must, look to a two-part test to defend the QTL. So the takeaway from the slide, from this whole presentation is, consider bringing a mental health SUD quantitative treatment limitation, or QTL, into compliance by removing or reducing any QTLs before moving on to a two-part test. So if you must, the two-part test will go into a description of the two-part test for mental health SUD QTLs. The two-part test asks two questions of each QTL type. So the first is substantially all. And this asks the question, does the type of QTL, like a visit limit, apply to at least 2/3 of the expected payments in a year for all medical surgical benefits in the same classification? If it doesn't apply to 2/3 of med-surg, then the answer is no. It's not compliant, and the QTL must be eliminated or modified. So if the answer is yes, it does apply to 2/3 of med-surg benefits, there's a little more work to be done still. And that asks the question, what is the predominant treatment limitation level, like, say, 30 visits? The second analysis determines the appropriate level of QTL as it applies to 51% of med-surg benefits. That's a lot of thinking to do about the process. So what I've done is provided a graphic description of the same process. So looking at this with a different view, we applied the substantially all test to evaluate the QTL, and then used the predominant test to determine the allowable level, such as 30 visits. So question one, does the type of QTL apply to at least 2/3 of the expected payments in a year for all med-surg benefits in the same classification? That's the outpatient and patient stuff. Now, if the answer is no, it doesn't apply to 2/3, then the QTL must be eliminated or adjusted. That's the box off to the right in red. So let's say, on option 2, let's say yes, that green box, let's say it does apply to 2/3 of med-surg payments. Well, then we do need, even if that's true, we need to make sure we have the right level or magnitude for that particular QTL. So that second question, does the level or magnitude of the QTL apply to more than one half of the payments for all medical surgical benefits subject to that type of QTL? So is this the predominant level for med-surg, for the med-surg category? If yes, we reach a level that is typical of 51% of med-surg benefits, then we have a level, a QTL, and a level that is compliant. If we can't get to the substantially all and predominant test, then the QTL needs to be adjusted. So it's a pretty high bar, and we're frankly more likely to get to the red boxes than to that final green box at the bottom left. So again, we were really counseling you to look at ways of making the QTLs compliant or eliminating them altogether, rather than trying to defend them using this process, which is unlikely to succeed. So how did we do it? How did OHA use this process of analysis to get to an analysis or a determination of which QTLs are compliant and which need to be changed? And I'm going to turn to Leah Forsman, who is also an analyst in this division, to talk about how she took on this process.
So hello, everyone. We've heard from Jason about what a quantitative treatment limitation is and what some of the alternative strategies for compliance are, such as removing the treatment limitations entirely or converting them to soft limits or non-quantitative treatment limitations. And finally, we've heard how to do the actual two-part test for compliance if you wish to preserve your quantitative treatment limitation. And now we'd like to provide you with an example of the steps that OHA went through when performing our QTL analysis. So step one was to identify all of our mental health and SUD services or benefits within the fee-for-service system. And to accomplish that task, we used our claims data to search for all the services that were paired with an F-code diagnosis. Now, exactly what we did was we selected a recent 6-month period of time in the claims data, remembering that claims tend to lag about 6 months, and we pulled all those claims with a billing code that paired with an F-code diagnosis. And now we had a list of all the mental health and SUD services. Now, just a quick aside that we chose not to use the HERC's prioritized list to identify all the F-code paired services, because the prioritized list does not include all ancillary services. And ancillary services are like the labs and x-rays and possibly anesthesia that would be associated with a particular treatment. So in order to be sure that you're including all of the services, you need to use claims data rather than the prioritized list. Now for step 2, we used our claim system to determine which of the identified procedure codes from step 1, representing our services, had a quantified treatment limitation attached to it, such as a day limit, or visit limit, or an item limit. And so what we were left with then was a list of all of the billing codes representing services with quantitative treatment limitations that were in the fee-for-service system. We also had to repeat that process for our DRGs, or our diagnosis-related group codes that are used for hospital billing, and for any revenue codes as well that were paired with an F-code diagnosis. Now for each of the QTLs that we identified, we considered the following options. We considered eliminating the quantitative treatment limit altogether for any diagnosis that might be paired with it. We considered eliminating the quantitative treatment limitation only when billed with an F diagnosis code. So this particular option would let you keep the QTL on the med-surg side of that service. We considered converting the QTL into a non-quantitative treatment limitation by making it a soft limit. And by soft limit, I mean that instead of always strictly reinforcing a quantitative treatment limitation, you could, for example, place a prior authorization on that service and make the limit subject to an individualized determination of medical appropriateness using medically appropriate criteria. Just keep in mind that you are going to need to make this criteria available upon request. And finally, we consider performing the 2-step test and confirming that the QTL was compliant with mental health parity regulations. Now for the fee-for-service system, we decided for the vast majority of benefits to either eliminate the QTL when it was billed with an F diagnosis code, or to convert the QTL to a soft limit. So we hope that this example has helped you to think, at least on a high level, about your own QTL analyses, and we invite you to submit any questions that you might have on this process to Jason Daniels, and you'll be able to find his contact information on the last slide.
Okay, so this is Jason Daniels again, and we'll work through the remainder of the presentation. What I wanted to also highlight now, in addition to some of the other setup and framework, looking at categorizing QTLs and doing analysis there, another aspect of the analysis relates to how this process covers the entire CCO system. So this is not only the hospitals and clinics that are what we think of as the CCO proper, this also puts a larger circle around the other contractors, subcontractors that are providing services under the CCO system. So this process involves identifying all of the entities involved in service delivery to a CCO's members. So this parity analysis must include all CCO operations, including subcontractors that provide med-surg and mental health services to its members, and set or apply a policy to treatment limitations. So let's sort of branch out on that to describe the underlying situations. So this involves identifying all organizations that provide services to CCO members and set or apply treatment limitations. This may include the CCO itself and subcontractors, including mental health organizations, independent practice organizations, county mental health programs, and prepaid inpatient health plans, among others. And another part of this is to identify the population served, and this might be broken out by administrative divisions such as county. So how does it all fit together in terms of doing analysis of the delivery system and how the overall parity analysis should proceed? So here's an example. If you look at the box on the right, we're talking about an example CCO that has its own operations and also contracts for mental health services. So the CCO sets and applies all limitations for its physical health delivery system. So that is unitary. But in each county, for mental health, the CCO has contracted with the CMHP to provide mental health services. So the CCO sets QTLs for all geographic areas and sets policy, such as prior authorization, for NQTLs, but the CMHP applies the NQTLs to members residing in its service area. So in this instance, when we look at this sample scenario where the CCO is handling the physical health treatment and the mental health is broken out across 2 counties, we have, for our analysis, 2 separate parity analyses being applied on 2 unique delivery systems. One delivery system is CCO plus CMHP for County 1, and a separate delivery system is for CCO and the CMHP for County 2. And this is done because there may be variations in how each of these county CMHPs applies NQTLs within their service area. So the rules may be set by the CCO, but their application in operation, and remember that was one of the criteria for understanding NQTL, their application in operation may be different. So looking at the effect of how the 2 entities in the 2 counties do their work in determining, say, a medical necessity needs to have a separate analysis in each of 2 separate delivery systems. Also, mental health services, just as a note, mental health services may be delivered by physical health providers, but even when they're provided by physical health providers, they are mental health benefits. So the analysis of the 2 systems follows that. So setting up for the parity analysis, this is another part of the sort of the cookbook for getting this done. Setting up for parity analysis requires that the CCO catalog all organizations that set or independently apply treatment limitations for CCO enrollees. And that would be for quantitative treatment limitations and non-quantitative treatment limitations. So this involves medical surgical, mental health, and substance use disorder treatment services by organization. So the next step then is to identify all combinations of organizations that set or apply limitations in unique CCO delivery systems. So this is, just remembering back to this example, we have two, in this instance, we have two combinations in two different service areas, but another scenario might happen where a CCO, even within one geographic area, is contracted to one or more organizations for mental health services. Again, and as an aside, remember that carved out services like prescription drugs, which OHA is going to be handling separately, and also dental services are not included in this analysis. So the next step in getting an alignment of service systems is the following. If a limitation is set system-wide, a separate analysis does not need to be performed in each delivery system combination. So what does that mean? For example, with QTLs might be more straightforward in analysis if a QTL is valid for all subcontractors. So if the CCO sets a QTL policy that is valid across its delivery system, then a single analysis would be required for the entire CCO delivery system, and that is, frankly, substantially less work than delivering separate permutations of delivery systems involving different subcontractors. Now, with the situation with NQTLs, you might see a different outcome in terms of what the scope of work that's required. NQTLs involve specific rules, which may be set by the CCO, and their application in operation. And that might be under the purview of subcontractors and therefore create this need for analysis of separate, unique analysis for each delivery system combination. So the point here is that the process of determining, say, medical necessities for NQTL is more contextual, and it may require analysis across multiple delivery systems. So just to pause, overall, across this presentation, we've looked at major topics for the final rule, the rule itself, its application, definitions for how the rule is applied, and we've also looked at setting up the analysis, both in terms of pulling and understanding the way that QTLs are evidenced in the overall systems for cataloging service, and specifically looking at quantitative treatment limitations. To preview webinar number 2, that webinar will be looking more at the non-quantitative treatment limitations. So there'll be a lot more information about how to think about and how to apply analysis for that group. So just highlighting the level of the types of resources that will be available to support you in doing this work. One thing that we've done is provided a set of links to the CMS resources that we've drawn upon, and this includes a version, or rather a presentation of the final rule itself, as well as other CMS guidance in terms of implementing the final rule. I'd like to point out that the implementation resources that CMS has provided are presented to the state to assist us in doing implementation at our end. Frankly, as you look at some of these resources, you'll discover that, as is often the case, they are fairly obscure and don't make it clear how the work is to be done. So these are resources. I commend them to you, specifically the final rule, which is the basis of this analysis, and understanding that some of the material in the final rule and in some of these resources just doesn't apply in the Oregon context, or may be more easily addressed by some of the work that we're doing than what's being laid out here. So we're bound by this, but remember that we can make it substantially easier. And that really is the role that we're trying to play here. We're trying to take this massive guidance and make it relevant and useful for you as you proceed through your analysis process. So I think this webinar is the first step. We will also be providing other resources as we move forward. We aim to provide technical support, and here's a timeline for some of that assistance. So webinar 2 involves the NQTL. Webinar 3 on April 20th will look at documentation requirements and start to bring in some of the topics that you raised from the questions that you'll be providing both through this webinar process and other question forum. So webinar 4 will really go to question topics and introduce our webinar time as an opportunity for each CCO to bring questions that you have and sort of share experience in a more unstructured way, in addition to dealing with some of the topics. And webinar 5 has the same basic structure. In addition, we'll be providing time slots to determine where you are in the analysis process and your needs for assistance in getting through that. So we'll be offering a one-on-one check-in where, rather than having an open forum, we'll be working one-on-one on looking at some of these analytical processes. And another date to highlight is the due date for the CCO's mental health parity analysis. So we do aim to provide a interpretation for the Oregon experience that helps you in your analysis. So we'll be providing an FAQ or FAQs as needed to address questions that come up. We'll bring those questions that you bring up not only in a written form, an FAQ, but also be addressing presentation or presentation topic up now. So if you have additional questions, you can send them directly to me. The email's here, and we'll begin sort of cataloging that and provide a systematic response to your questions. And I would say just in closing that we appreciate the opportunity to work with you. We very much see this as a partnership, and we're doing everything we can to provide help along the way that will make this a more intuitive and straightforward process to get the work done. So we appreciate you taking the time to spend with us today to issue your questions, share your questions with us, and we look forward to working with you through this process. So again, thank you, and we look forward to meeting with you in further webinars and in the one-on-one opportunities that are coming up. So thanks again, and have a great day.